Wonderful morning to each one of us. Welcome to another exciting webinar, MPN, Young People and Pregnancy, brought to you by Mumbai Hematology Group. And we are extremely proud to present the same. Grateful to our program director, Professor Dr. M.D. institution and teacher of teachers who have been coherently collaborating across the world to bring this all together every Saturday and Sunday. A warm welcome to our moderator, Dr. Amit Khurana. We know him very well, an experienced transplanter and hematologist in the country, practicing in the western part of India, Surat, almost a decade plus experience, and a large number of patients have been benefited because of his transplant, and he does both auto and allo transplant. Amit Khurana sir to take it forward, introduce our chief guest and also our chief speaker.
Thank you, Dr. Manoj Kumar. Well, very good morning to all of you, and good afternoon and good evening to rest of the people from rest of the world. Today, our guest speaker for the day is Professor Claire Harrison from London, UK. She's going to lecture us on MPN for young people and pregnancy. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS, and perfectly managed by Perfect Square. I thank Dr. Manoj Kumar and team INTAS, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Colonel Dr. Rajan Kapoor from Delhi, our guest speaker for the day, Dr. Claire Harrison from London, UK, all our discussants who are themselves eminent hematologists or medical oncologists, and you participants for spending your Sunday morning, afternoon, and evening. Next Saturday, that is on 11th March, we have a webinar on bleeding disorders in female patients, causes and conundrums by Dr. Meera Chitlur from Children's Hospital of Michigan. And the following day, that is on 12th March, Sunday at 11:30 a.m., we have a webinar on molecular genetics of BALL, recent updates and diagnostic tools by Dr. Sanjeev Kumar Gupta from AIIMS, New Delhi. Let me introduce the discussants for the day here displayed in alphabetical order. To start with, we have Dr. Abhay Bhave from Lilavati Hospital, Mumbai, Dr. Aditya Jandial from PGI Chandigarh, Dr. Ami Patel from Shashwat Super Specialty Center, Surat, Dr. Liu Prince Mathan from KEM Hospital, Parel, Mumbai, Dr. P. Prabhu from Apollo Hospital, Chennai, Dr. Rajasekhar Thirugunanam from Kovai Medical Center and Hospital, Coimbatore, Dr. Sachin Yadav from HCG Group of Hospitals, Bengaluru, Dr. Santanu Sen from Kokilaben Tirubai Ambani Hospital, Mumbai, Dr. Sridhar Gopal from Sri Ramakrishna Hospital, Coimbatore, Dr. Sunil Bhatt from SRCC NH Children's Hospital, Mumbai. Now it's a time to introduce our special guest for the day. We have with us Colonel Dr. Rajan Kapoor from New Delhi. Dr. Rajan Kapoor is MD, DNB Medicine and DM Clinical Hematology, Professor and Head at Department of Hematology and Stem Cell Transplant at Army Hospital, RNR, New Delhi. Dr. Rajan Kapoor did his DM in Clinical Hematology from AIIMS, New Delhi from 2008 to 2011. Earlier, he did DNB in Internal Medicine, NBE 2004, and MD in Internal Medicine from AFMC, Pune in the year 2000 to 2003. He is recipient Armed Force Medical Research Committee, AFMRC Research Grant, and Award to study genetic polymorphism of patients of warfarin in Pune 2016. He was awarded Vishisht Seva Medal for exemplary service by President of India, Pune, India in the year 2014. He also received United Nations Medal for UN Mission Democratic Republic of Congo in 2007. He is recipient of Hari Malini Gold Medal for standing first in MD Medicine, University of Pune in 2003. He is Associate Editor of Indian Journal of Hematology and Blood Transfusion, IJHBT. He is Member, Education Committee of Indian Society of Blood and Marrow Transplantation. He designed software and CRF for data collection for multiple centers for AML and CML, which is being used by Hematological Cancer Consortium, that is HCC. He has over 96 publications to his names, including chapters in books. He has keen interest in data-based clinical analytics and development of apps for use by hematologists. His special areas of interest include hematopoietic stem cell transplantation and bone marrow failure syndromes. It's my privilege to invite him to inaugurate our webinar and give some words of wisdom. Over to you, Colonel Dr. Rajan Kapoor.
Thank you. Thank you so very much, Amit, for such an elaborate introduction. A very good morning, good afternoon, or good evening to everyone in different parts of the world. It's indeed a proud privilege for me to be invited by Professor MB Agarwal to be a chief guest for this webinar. We all look forward for last 2-3 years, started with the COVID pandemic on the Saturday and Sunday to attend this academic fest. So my journey actually as a hematologist started in 2002, around 2002, 2003, while I was doing my residency in internal medicine, and my thesis topic was megaloblastic anemia. Back those days, we did not have an access to all those articles. So I wrote a mail to Professor MB Agarwal that I needed some material. And within a week, I got a hardbound copy of Hematology Clinics of North America on megaloblastic anemia. So that was the time when I fell in love with hematologists. So whoever the junior colleagues and the residents who are there, we need towering figures like Professor MB Agarwal to promote hematology. And I'm delighted to see that even in small cities and towns, now the hematologists are making a difference, and that should carry forward. So today, I just would like to say that now we are at an inflection point, the technology. Now, the technology has brought a transformational change. So now all of us maybe have heard about the ChatGPT, artificial intelligence. The question which is often asked, can we compete with AI? So the answer is no, but we still can be very relevant in this time, even in the times of artificial intelligence. So how do we stay relevant in these times? The first and foremost is innovation. We should stress on innovation and take help of AI. I'll just give an example. In last COVID times, when we had some time at our hand, I was always in awe of these statisticians, software developers, apps and all. So I thought that I'll give a hand to coding. I learned coding in design apps. And when you do that, and when you have your own knowledge, your own problems, and you design it yourself, you can actually make solutions. So that's how you should use artificial intelligence to your aid. Second point is learn to be a very effective team player. Now, individual brilliance is good, but the most important thing is how important you are to the team. So your team, you should contribute. Second, what is very foremost, whether it is your career planning or the patient care, your endeavor should be continuous learning and upgradation of skills. Now, these webinars, I'm thankful to sir and everyone here that every Saturday, Sunday, I mean, it was impossible for most of us to listen to these eminent speakers like what we have, Dr. Harrison today. Now, with these webinars, we can actually upgrade our skills. Third is that when you decide on career, never have that fear on missing out, the next gen FOMO, what they say. Now is the time of transplanters, CAR Ts and whatnot, but we should remember that there is so much of the work, especially in our country, to be done for disorders like thalassemia, sickles, iron deficiency, megaloblastic. So if you are working on that, it would be a good career choice and you're not missing out on anything. Do not try to ape someone who's doing high-flying things. Decide for yourself what is good for you, work on that, publish a lot, and that's it. Now, the other thing is for AI, there are many things which can be given to AI. There's a lot of talk whether AI will replace us or not. I will just give an example. Yesterday, I was taking a talk in All India Institute about aplastic anemia. I was making my presentation. So I told ChatGPT to make my introduction, the conclusion, and give me a poem about aplastic anemia. And it was fantastic. I couldn't have replicated. I put my stress on my data, what I wanted to say. So you can use AI as well and try to improve your skill. So with this, I would say I wouldn't stand in between. I'm very excited to listen to what Dr. Harrison has to say on MPNs, and especially a very important thing that young and pregnancy, where always we are looking for answers, not only the patients and we too. And thanks a lot and all the very best for a webinar. Back to you, Dr. Amit.
Thank you, Dr. Rajat Kapoor, for the great words of wisdom. It means a lot to us. Thank you so much for being with us today. Now it's a time to introduce our guest speaker for the day, Professor Claire Harrison from London, UK. Dr. Claire Harrison is Professor and Deputy Medical Director, Research and Clinical Director, Department of Hematology at Guy's and St. Thomas Hospital NHS Foundation Trust, London, UK. She is an international expert in myeloproliferative neoplasm, and she has influenced major advances in MPN, including the description of key mutations and designing and leading global clinical trials, including the first JAK inhibitor trial in Europe. She is a chief investigator for several other international and national clinical trials. She has very strong international collaborations in France, Germany, Spain, and the USA, amongst others. She has authored many papers in peer-reviewed journals, such as the NEJM and Blood. She regularly contributes to British Society of Hematology and the European Hematology Association. She is a founder of MPN Voice, is an advisory member for the MPN Education Foundation. She collaborates with MPN Research Foundation. She also works with other patient charities such as Blood Cancer UK and MPN Research Foundation. She is also an advisor to Leukemia Care and Bloodwise medical charities. Her education was in Oxford University, University College Hospital, and Great Ormond Street Hospital, London, UK. She is recipient of Dunhill Medical Fellowship in 2012 and achieved NIHR Clinical Researcher Award in 2017 and 2018. She has been Tisch Visiting Professor of Hematology at Mount Sinai in 2012. She's going to lecture us today on MPN for young people and pregnancy. Well, thank you so much. Over to you, ma'am, for your lecture.
Well, thank you. Thank you for the opportunity to join your wonderful group. And thank you for those amazing pre-words. I couldn't agree more about picking something that you're interested in and passionate about. And I also really agree about AI, technology, data and clinical analytics, etc. It's super interesting and has the power really to help us and our patients. I recently picked up leading the data and analytics strategy for our hospital and really has opened my eyes to opportunities. But as our colleague said, we do still have a strong role to play, and the topics that I'm going to discuss with you today, if we move to the next slide, are ones which are dear to my heart and are areas which I had found difficult when I first began my independent clinical practice as a consultant. And these are the management of young patients with MPN and also of pregnancy. So turning first to considerations and experiences for young patients with MPN. I wonder if you're feeling any of these things when you see somebody maybe who's 18 with a platelet count of 1,450. Are you thinking, I've never seen an MPN patient aged less than 25 at diagnosis? Are you feeling totally comfortable in managing these young patients? Would you send them to an expert centre? Or maybe you would manage them the same as you would if they were an adult, i.e. more than 25 years. I suspect this is a mixture of feelings, actually. But I think this is a relevant area. One, it's not that uncommon to see MPN in patients who are aged between 20 and 40, even though the median age at diagnosis is 60. They overall will represent about 10% of cases. So this is cases less than 25 at the time of diagnosis. But if you look in the literature is quite scarce and it's incomplete. And so we began a collaborative effort across the European Hematology Special Working Group. And this is a free-to-join collective of interesting parties across EHA members. We first did a literature review, and then we decided to prospectively collect data across centres. Just trying to move the slide on and it doesn't seem to want to go, but we'll try again. Here we go. And so the asterisks represent the countries that were involved in this collaboration. Oh gosh. Maybe the person who's controlling the screen can move back. You can tell how many times I tried to move the slides forward, right? So we had...
Mr. Kalpesh, can you please move the slide back?
If you go back, I'm so sorry.
Yeah, no issues, ma'am.
I was impatient, which is not a virtue.
Mr. Kalpesh?
Yes, we're going backwards. Please keep going back until you see the map.
Yeah.
There we go.
Yeah.
So we had 40 different clinicians involved and 14 different countries, including Taiwan. And it would be really nice next time we do this kind of effort to include colleagues from the Indian subcontinent and others who joined this meeting, because I know this is really an international meeting. Please move to the next slide. As we're moving, you can see that most patients, however, came from Poland, France, United Kingdom, and Germany. Okay, I'll try to move the slide. Here we go. These are the patients that we collated the data from. So there were 444 patients. The median age at diagnosis was indeed over 20, but if you look, the youngest patient that we included was less than 1. We included patients during their follow-up, so the median age that we included patients in when we were collecting their data was 28. But we had some patients who had been diagnosed less than 25 years of age, who were in fact over 60 at the time when we collected their data. So the point of this is that we actually had quite long follow-up. Of all of the subtypes of MPN, most patients, indeed 89% of them, were either ET, which was by far the commonest, or PV. So it's very difficult to make conclusions about myelofibrosis from this data set. What about the characteristics of these patients at diagnosis? Well, the circumstances of diagnosis are shown here on the left of the slide, and you can see that, oh, why's it doing that? Okay, I've worked out why it's doing it, I can control it. For the most part, and if you go to the next slide, thank you so much. For the most part, that's too far. At diagnosis, patients had an abnormal blood count, or they may have had signs and symptoms. So that was almost 80% of patients. And the signs and symptoms that they presented with are shown on the right-hand side of the slide. Hyperviscosity symptoms were very common in young people, or they presented with palpable splenomegaly or fatigue. Microvascular symptoms were present in about 10%. And in a recent online collection of young patients with MPN from Europe, the majority of them had headaches and visual symptoms, which was very interesting to me. Thrombosis occurred in about 10% of patients at the time of diagnosis, and around 10% of them were pregnant at the time of diagnosis. And as we move to the next slide, you'll be able to see, thank you, no, it's gone too far again, characteristics and in terms of blood count features at diagnosis. We'll go back. Hopefully it will stay stable on this slide. So as you'll see, we basically decided that we would group the non-ET and non-PV patients together. So as I said before, it's quite difficult to make any firm conclusions about those patients as a consequence. But what you can see here are the significant differences between the cohorts. Not surprisingly, classically, the ET patients had an isolated thrombocytosis, and the majority of them were female. Conflicting, the PV patients, of course, had an elevated hemoglobin, but also a higher white cell count. They were more commonly symptomatic, more prevalent hyperviscous splenomegaly, fatigue, and, as we would probably expect, more aquagenic pruritus. By contrast, leukocytosis, the presence of that was more likely to indicate a non-ET or PV MPN, and constitutional symptoms also was likely to indicate a non-ET or PV MPN. Now, moving to the next slide, you'll see the driver mutation status for these patients. And these really mirror very much, for the most part, what we would expect to see in the adult population, except I expect those keen-eyed of you will notice that a triple negative, or as we've labeled on this slide, 3 negative, driver mutation status was more prevalent than we would expect to see in the adult population for ET patients. So young female patients with a high platelet count, around a third of them would be triple negative, but according to the treating centre, they would still meet the sufficient diagnostic criteria to have a diagnosis of ET. Where we had data about the JAK allele burden, that's shown underneath the pie charts, and you can see pretty much, again, as we would expect, on the whole, PV patients and MF patients had a higher allele burden than ET patients, but it's not enough to be able to discriminate between these entities. As we move forward onto the next slide, I think there's a little bit more information about these patients. Here you can see the range in the ET patients of the different driver mutations in different age brackets. And here you see another striking finding, that often the patients who were labelled as having ET, age less than 10, were triple negative. And JAK2 positivity and CALR positivity, of course, became more prevalent over time. But I think this is striking, and I'm wondering whether these patients, as we go back and look at them in more detail, really had a long-term follow-up that was consistent with ET, or whether they had something that transiently resolved. Next slide, please. Let's see how we get on. So now we're going to talk about what happened to the patients over follow-up and their treatments. I told you about how old the patients were when we collected the data, And here I'm showing you what their median follow-up was, which was almost 10 years, but ranged up to almost 48 years. And overall, 40% of patients had at least a decade of follow-up. Focusing on treatment, antithrombotic drugs were used by 76%, and phlebotomies were quite frequently used. Concerning the antithrombotic drugs, you can see that for the most part, this was low-dose aspirin only, but around 20% of patients had additional therapies, vitamin K antagonists such as warfarin or other coumadins, a DOAC, or low molecular weight heparin. And this was just the first line of therapy for these patients. Now, I've asked the slides to move forward. Here we go. Cytoreductive drugs. So another surprise, around 2/3 of these patients received a cytoreductive drug. And we made a comment that more of these drugs were given than we would expect according to international recommendations. So we went back and looked at these patients and found that overall, we would not necessarily have expected them to have a drug. Perhaps this reflects changing recommendations over time, but nonetheless, it's quite a striking finding. Here you can see the different agents that were used for these patients. Another finding here that around half of them were having hydroxycarbamide, a quarter interferon, and just over a quarter receiving anagrelide. Some patients had ruxolitinib as a first therapy, and some had other agents in the past, such as busulfan. And here you can see these agents split out according to the different disease types. Perhaps not surprisingly, much less anagrelide given to PV patients. Concerning vascular complications, as we already mentioned, around 10% of patients had a vascular event at the time of diagnosis. But recurrent events after the time of diagnosis are higher than we would have expected in what we might otherwise have called a low-risk population because of age. So new events after MPN diagnosis occurred in 11%. Around a third of patients who'd had a thrombotic event already had another one. And of these thrombotic events, about 70% of them were venous, which is again in conflict to what we would expect in the literature. Hemorrhage was also quite prevalent, occurring in about 10% of patients after diagnosis and 5% before the time of diagnosis. And here you see the Kaplan-Meier plot for probability of thrombosis-free survival, with the median not being reached. And you can also appreciate the very long follow-up for some patients in this study, which is very important because actually the question we have for many young patients is, what will happen to this patient over time? A little bit more detail here about the cumulative incidence of thrombosis across the cohort. And you can see here that thrombotic events were at every time point more common in the PV patients, but really there wasn't much difference between PV and ET at the 10-year time point. And overall, the risk of thrombosis didn't really correlate with the MPN subtype. So sorry, went a bit too far. Here you can see, okay, we'll stay here and then we'll move to the other picture. So concerning thrombosis and mutations in ET patients, as you will be aware in the literature, we expect to see more thrombotic events in JAK2 positive patients and almost no events in triple negative patients. This also holds true for the young patients. Here you can see that thrombosis was more common in the JAK2 population, but you will also see that some of these triple negative ET patients did indeed have thrombotic events. Okay, we will go back because I'm desperate to show you this picture, even though the slide doesn't want to stay here. Okay, well, I'll give you the message. The message for the two humans on the slides is that, as we already heard, thrombotic events are more common, but really interestingly, in this patient cohort, it is the splanchnic vein thrombosis that we have to be really aware of. It is far more common in these patients. We then tried to look at what could we use to predict thrombosis for these patients. And we used, to start with, the IPSET thrombosis score. We were missing data for some patients, but you can see for the vast majority, it was only 8 patients that we missed events for. But you can see for the vast majority, we had sufficient data. You can also see that we could use this score in this population of patients. So new thrombotic events occurred more commonly in patients who had a high IPSET score. And the corollary, a low IPSET score, was reassuring. What about hemorrhagic events? I mentioned these were about 6%, evenly split between the entities, and new episodes occurred about 1% per patient per year. And again, these were roughly evenly split between the entities. Interestingly, perhaps slightly less common in the ET patients, although this was not statistically significant. Here you can see a few things. On the left, the bleeding events by the patient group, not statistically significant, and also bleeding events in the ET population according to the driver mutation status, again, not statistically significant. Remember that really the difference in bleeding between these events, even in these subtypes in the adult population, is not really different. What could predict bleeding in both the whole cohort and in the ET population was a previous history of bleeding and a very high platelet count, so more than 1,500, perhaps not surprising. Of course, a major concern for many MPN patients is the risk of transformation. And there were nearly 50 transformation events. Most events, however, were for ET patients transforming into PV. Followed by into MF, which occurred more frequently in ET patients, but remembering that the ET patients were by far the majority here. Transformation events occurred at about 2.5% across the cohort and were slightly more common in PV patients, and overall less than 1% of patients developed AML in this very long follow-up. You can see overall survival, and here is a limitation of our data. There were only 8 deaths in this cohort of 444 patients. So the median overall survival is not reached. And you can see the causes of death on the left. Bleeding, leukemia spelt wrong, apologies for that. 1 patient dying after transplant, 1 with a CMV pneumonia, 1 with liver insufficiency, so pointing out that splanchnic vein thrombosis is not a benign condition. One patient had a solid tumour and there was one unknown death. The probability of survival median was 35 years. And that was in the non-ET or non-PV group. What about maternity? So I have a separate slide concerning management of pregnancy, but this is really a big cohort of patients in centres where we haven't always collected data about pregnancy. And overall, there were 119 women experiencing pregnancies, 134 live births, 6 pregnancies were ongoing at the time of data collection, and the live birth rate was about 78%, which compares well to the literature. 20% of patients were not treated with a cytoreductive drug in pregnancy, and among those treated, there was a need to switch their first-line agent. Many of these were switched to interferon from hydroxycarbamide or anagrelide, for example, and some were switched just from anticoagulation with an antiplatelet agent alone to the addition of interferon, which would be the cytoreductive agent we would use in pregnancy, of course. In conclusion, there is more work to do, and we are currently looking in more detail at this subset. We found that young patients with MPN are not so rare. All subtypes of these conditions are represented, but there was a predominance of ET in young women. The mutational landscape generally was similar to older patients, but there is this sense from our data that prescriptions, interestingly, of antithrombotic and cytoreductive drugs were higher than would be expected. This may reflect historical bias, but it could also reflect nervousness in the treating clinician. There was overall a high rate of complications, 10% of thromboembolic events at 10 years approximately, and the cumulative incidence of transformation with a high proportion of secondary myelofibrosis was 6% at 10 years and 10% at 20 years. Interesting data and important to keep in your mind when you see these patients. These are only the medical experiences of this patient cohort and not the whole patient experience. And I think that these young patients often suffer greatly with the knowledge that they have this condition, with the uncertainty about the future and questions about how to deal with this in their day-to-day lives. So what has our plan as the EHA, SWG and owners of this data be? So we've published the data and we're sharing and talking about it, just like I'm sharing and talking about it today with you, our wonderful audience this morning. We plan to collaborate to pull together international guidelines for diagnosis and management of young people, and we will work with patients to do this across our European and international networks. And so I invite 1 or 2 colleagues from your network, Professor Agarwal and others, to join our collaborative and to join in and contribute on behalf of your patient and clinical communities. We wish also to form a supportive network of young people with MPN and learn about their experience and allow them to mutually support each other. And in fact, I began to do that 3 weeks ago in another Zoom session, and we will be doing an additional Zoom session in a couple of weeks' time to try to get them to share their experiences. And this is how I learned about many of these young people, for example, having visual symptoms. And as a clinician who's practiced as a consultant for more than 20 years, I would say I learn a lot from listening to my patients. I learned a lot about MPN, a chronic disease, by listening to my patients in meetings in collaboration with them. So I'm really looking forward to this, and I would like to try to find a way of reaching young people again within your networks. I want to move on to the second topic, and I want to acknowledge Susan Robinson, who is my colleague from Guy's and St Thomas's. In this picture, you can see St Thomas's Hospital on the right-hand side opposite the Houses of Parliament on an uncharacteristically sunny day in London. So the model of obstetric care and haematology at Guy's and St Thomas's we thought would be useful to share with you, because I know that our audience is very broad in their interests. Indeed, our special expert today has an interest, as I've heard, in aplastic anemia and megaloblastic anemia, as well as in other aspects of haematology. So we have, as a group of haematologists who are interested in obstetric haematology, a meeting with the fetal medicine unit as a multidisciplinary meeting. And for the most part, here we are discussing the management of women with alloantibodies such as anti-D and others in pregnancy. But we will also discuss women with other problems coming through our unit. There is a general obstetric haematology clinic which happens every week. Here, MPN patients are managed, but also patients with low platelets and anemia and other conditions in pregnancy. We have a large population of patients with haemoglobinopathy and especially sickle cell disease in South East London, and these patients are managed in a separate specialist clinic, as are patients with antiphospholipid and bleeding disorders. We send a haematology consultant and team around the wards for women's services, and they are represented on the hospital transfusion and also the thrombosis and thromboprophylaxis committee. What about MPN? We already heard about age-specific incidence rates, but I just wanted to point out that the pregnancy age, of course, is a bit wider than the age we were just talking about. And we do, of course, see women in this age range. And I think our thoughts about how these women are managed and treated has evolved over time. If we think about the most prevalent MPNs in pregnancy, of course, this is likely to be PV and more prevalently ET. In a meta-analysis of 779 women and 1,226 pregnancies, which comprise 19 retrospective and 3 prospective cohorts, the live birth rate was 70%, so slightly less, but equivalent to what I just showed you. And better perhaps in ET than PV, but of course, there are differences in numbers of patients, and there is also a publication bias, whereby we're more likely to publish difficult cases here, because of course, this is a little bit more sensational, I would say. Myelofibrosis, slightly less prevalent. The most recent series came from the Mayo Clinic and Florence and was published by Naseem Gangat in the British Journal of Haematology in 2021. Overall, 24 pregnancies in 16 women, live birth rate similar, 71%, fetal loss 7, predominantly in the first trimester, so possibly unavoidable. There was 1 intrauterine growth retardation and 2 preterm births. Maternal complications here occurred in 5 pregnancies, so again, pretty high. Hemorrhage 3, preeclampsia 1, and gestational diabetes, possibly not related to MPN, I would say, in 1. In carrying out their systematic review and meta-analysis, the Canadian group led by Dawn Mays reported that the live birth rate was higher in patients with ET who received low-dose aspirin during pregnancy than those who were managed with observation alone. Interferon alpha treatment during pregnancy was also associated with a higher birth rate. You'll notice that the confidence intervals around these figures are quite wide. Interestingly, in this analysis, there was no further improvement in the live birth rate with the addition of low molecular weight heparin to aspirin. But of course, if you're faced with a patient who's had a venous thrombotic event, I would say aspirin prophylaxis alone is not sufficient. So regardless of what this data says, you must still give these women some additional form of anticoagulant. But think about adding aspirin if you think it's safe in pregnancy. Most recently, in preparation for this lecture today, I pulled out this beautiful paper that's come from colleagues in Sweden. And in Sweden, they have very large cancer registry and a nationally collected health database. Imagine that. We don't have that in the UK at all, but this is the power of big data. So here they were able to identify 342 pregnancies and match them to controls. Again, you can see if you look down the left, the majority of patients had ET and the majority were diagnosed with an MPN prior to pregnancy, but around 1 in 5 had the diagnosis during pregnancy or in the postpartum period. 229 patients had a pregnancy after an MPN diagnosis, and the data for these patients are shown on the right. Key messages from this paper, which is beautifully written, I would urge you to read it, and it's the most up-to-date one. 1. MPN pregnancies are more common than previously expected. In the only other large prospective study, which was carried out in the UK using the UK obstetric surveillance system, where obstetricians are sent a reporting card on specific topics once a quarter, and we did one of these for MPN, we found that the prevalence was around 3.1 per 100,000 births. In Sweden, it was 12.2 per 100,000 births, probably because of better reporting. Interestingly, they found that there was no major increase in risk of adverse maternal outcome. There were 3 episodes of venous thromboembolic events, none in the controls, but this was not statistically significant. And importantly and interestingly, there was no increase in bleeding. They could comment on outcomes of the newborn child in terms of gestational age, birth weight, and mortality. And they did see an increased risk of small for birth weight babies in the MPN pregnancies and an increased rate of preterm deliveries. Stillbirths did occur more frequently, as did fetal malformations, but these were not statistically significant. One important limitation of this data is that they did not collect data on pregnancy losses in the first trimester, so we can't comment on that from this data set. Also, they couldn't really comment on the impacts of driver mutations and pregnancy outcome. And I want to touch on that now. And again, it's specifically relevant to ET patients. So in our day-to-day practice, if I was talking to you about how to manage ET this morning, I would say that increasingly CALR and triple negative ET patients are being considered for de-escalated therapy. And that's on the basis of the kind of data that you see on the left-hand side of the slide. And this is about risk of thrombosis. In pregnancy, there's really conflicting data. A case series from Canada suggested that JAK2 positive and triple negative patients had a greater risk of pregnancy loss. But there were only 29 patients in this data series. And this was published by Dawn Mays again in the European Journal of Haematology this year. I think we should be very cautious about over-interpreting that, but nonetheless say that there are still risks in triple negative patients. In my hospital and in our team, we do not change practice according to the patient's mutational status. How do we manage and how do we think about pregnancy? Pre-conception and during the first visits for patients who are of childbearing potential, both male and female, we will discuss with them potentials for management of pregnancy, and we will counsel them to talk to us if they're planning a pregnancy. And if they are, we will then do a risk assessment and optimize them before they begin to consider conceiving. So we would optimize control of their blood counts, encourage them again to address cardiovascular risk factors. We saw gestational diabetes, maybe that was related to body weight, and review the cytoreductive agents. So we would switch, for example, to interferon alpha before the pregnancy occurred, if possible. Occasionally, patients will fall pregnant on hydroxycarbamide or anagrelide, and then we just tell them to switch, and we would do an abnormality scan, and we can be relatively reassuring about these agents. We would offer low-dose aspirin to all patients, venesection for PV patients with a lower target hematocrit, and offer low molecular weight heparin in the presence of one additional thrombosis risk factor, which could be advanced maternal age, which could be the use of in vitro fertilization, etc. All patients have an anomaly scan and uterine artery Doppler scan at 20 weeks, and we will offer serial grade scans. We tell them to, like all pregnant women, but particularly in this group, avoid dehydration and immobility. And if they do fall into that situation, we need to know, because we would probably want to support them and perhaps give them low molecular weight heparin. High risk patients for pregnancy are all patients needing a cytoreductive. And these patients would all have a cytoreductive agent and, for the most part, low molecular weight heparin. These include all patients who've had 2 or more early pregnancy events, and may also include those patients who've had 1 prior late pregnancy event, such as preeclampsia, intrauterine growth retardation, etc. These patients, as I've said, would get interferon alpha, low molecular weight heparin if they've had prior thrombosis and if they've had poor prior pregnancy outcome. And these patients would all have increased fetal monitoring. Post-delivery, all patients should have low molecular weight heparin for 6 weeks, even if they're not routinely on an anticoagulant. And we would continue the aspirin according to management of MPN prior to pregnancy. We'd have an individual breastfeeding plan, but in general, we encourage our patients to breastfeed even if they're on interferon, on the grounds that it's not excreted for the most part in the breast milk. It's not orally active, otherwise we wouldn't be giving it as an injection. And the newborn gut is very immature and doesn't absorb many nutrients. We would also want to discuss contraception, of course. So that's the schema that we use in GSTT for managing pregnancy. Let's discuss some cases before closing off today's session. So here is a 22-year-old lady with a diagnosis of JAK2 positive ET. She attends clinic and asks for advice about contraception and future pregnancy planning. She initially presented with migraine-like symptoms and an elevated platelet count. Currently, she's taking aspirin, has a platelet count of about 689 and is not on any cytoreductive therapy. So I'm wondering what you would think in your mind about advice about contraception. We've already thought about pregnancy for this lady, right? So our advice for contraception would be to avoid estrogen-containing contraceptives. We would suggest a progesterone-only modality, which could be any of those listed here, or barrier contraception. If she does fall pregnant, she's a low risk for pregnancy, so she would have aspirin and just postpartum low molecular weight heparin. But imagine this patient comes back 2 years later because she's not pregnant, and she's had some fertility investigations which have identified that the issue lies with her partner, and now she's planning to have undergo in vitro fertilization. The platelet count is still below 700. However, there are differences in the way we approach a pregnancy in a woman who has undergone IVF. The use of IVF renders a patient high risk for pregnancy in terms of risk of thrombosis. And so we would add low molecular weight heparin from the time of hormonal stimulation for the IVF. She would have enhanced monitoring, low molecular weight heparin through pregnancy and afterwards. Here's another lady, she's a bit older. She's already had one previous pregnancy where she took aspirin. She delivered at 36 weeks because there was a deterioration in growth scans, and the child was small for gestational age. This patient is high risk, and we would offer, well, belt and braces really, aspirin, heparin, and low molecular and interferon. But we would stop the interferon, of course, in the postpartum period. The PV is another patient, 26, referred for an opinion, already pregnant, no prior obstetric history, currently on low-dose aspirin and venesection. So you will have spotted that her hematocrit is well over target. So wondering what treatment you would offer this patient. Aspirin only, aspirin, low molecular weight heparin, aspirin, venesection and low molecular weight heparin. Are you worried about venesection in pregnancy or not? Just aspirin and venesection, and then low molecular weight heparin postpartum. Have a think in your mind. So my answer would be D. This patient is low risk in pregnancy, but the hematocrit is not adequately controlled. And I would just remind you that the hematocrit naturally falls in pregnancy. So beyond the beginning of, or the end of the first trimester, we would manage our patients to a hematocrit target of about 0.38 to 0.4. So I want to end there and thank you very much for bearing with me with all the technical issues. Thank you to the team at Guy's and St Thomas's. This is a picture of Guy's Hospital. And I look forward to discussions. Thank you very much.
Thank you so much, Dr. Harrison, for that wonderful lecture. It was super fantastic as usual. So now, ma'am, we'll move with the question answer session with our Indian colleagues. So would you like to take a break, ma'am, or should we start?
Oh, no, I'm very happy to start. That's fine.
Thank you so much, ma'am. So we have first Dr. Sunil Bhatt. Dr. Sunil Bhatt, your question, please.
Good afternoon, everyone. And first of all, apologies for my bad throat. I'm down with a viral. Excellent session, Dr. Harrison. I think it was so clear and so crisp on a very difficult topic. I got 2 or 3 questions. One was on the data set which you showed from the multi-center data. I'm a pediatric hematologist. I just wanted to know, was there a difference between younger patients, maybe less than 15, versus the older patients in the in the data, especially in the context of thrombotic events which you showed? That's one question I have. The second was also, we always kind of worry when some of these young women conceive while they're on cytoreductive therapies already. And you showed that data from Sweden, wherein so I we could just throw some light on that. Was there any difference between the ones who had conceived while on cytoreductive therapies, or versus those who had, of course, stopped it before the conception? And the third, if I'm permitted to ask, is also in regards to pediatric population. We come across very often, in our part of the world, thrombocytosis, and you sometimes investigate, you don't find a reason. So in your practice and, with your experience, what would you say are the red flag signs when I think we should, especially the ones who are probably triple negative on the workup? So which are the red flag signs to have a higher interest of suspicion for ET in these younger patients? Thank you.
Well, thank you so much, Dr. Button. I wish you a speedy recovery from your virus. It didn't show. You asked fantastic questions. Let's start with the last one, because I think that's probably the most practically relevant, and it's difficult, right? It's actually even difficult in the adult setting, but as you rightly say, I think that isolated thrombocytosis is more common in the pediatric setting. Well, red flags to me would be clearly the unwell child, a child with maybe a family history, a child with palpable splenomegaly, always a concern, although perhaps less so, in areas where splenomegaly might be a little bit more common for other reasons. I'm thinking about tropical splenomegaly, for example. You maybe see splenomegaly in children a bit more than we would in London. And I think also, a child with anemia, symptoms, leukocytosis, I would always want to look hard. I think in a young child, we're always perhaps a little bit reluctant to do a bone marrow biopsy. And I would prefer to intensively investigate and follow the child over time before jumping straight to a bone marrow biopsy, which we might do in an older adult with a platelet count of 1,000 or so. We might just say, oh, we need to do a bone marrow biopsy if the driver mutations are negative. I do not think, we didn't show this data, but I do not think that spending money on an extended next generation sequencing panel is worthwhile in this setting. It's usually negative, especially in the younger patient. So I think that, your typical red flags, and maybe you want to come back and add some more from your practice, which I think is probably more extensive than mine. But ultimately, you do sometimes have to do a bone marrow, and then it can be helpful sometimes to send that biopsy off to a pathologist who is expert, both in pediatric hematology, because their marrows are often, they're often very cellular, aren't they, as we would expect. So, that's one of the key findings in MPN already gone to help you. Next, you asked about the Swedish cancer data and could they look at patients who were already receiving a cytoreductive agent when they got pregnant and whether there was any difference. Well, a few words on that. One, in Sweden, they give a lot of interferon, especially to young women. So I think there were probably very few, and certainly that is not something that was pulled out in that data set. I'm examining that work as a PhD in the next month. So thank you so much for giving me that question to ask in the thesis, Viva. I would expect, and just want to make the point though, that patients with a previous thrombosis are often those who we are treating with a cytoreductive, and they often have the likelihood of worse pregnancy outcomes. So we do see a slight increase in risk. And then your other question was, do we see a difference in thrombotic risk across the age spectrum in the younger patient cohort? And no, I do not think we have seen this, but I don't think we've looked at it. And I also think there's the thing also about presentation bias. So young children don't routinely get a blood count unless they've got a problem. So I think it's quite difficult to tell. And I suspect there wasn't a difference. But again, that's something we're still looking at. Thank you so much for your questions.
Thank you. Thank you.
Thank you, Dr. Sunil Bhatt. Dr. Abhay Bhave, sir, your question, please.
Thank you very much, Professor Claire Harrison. I think it's always a pleasure to listen to you. And what hits hardest is the clarity and the kind of data, including the duration of your analysis. So thank you very much. It has helped me to speak more effectively with my patients, the kind of data that you churn out. If Dr. Khunana does not mind, I have got 3 or 4 questions for you.
Oh, sir, sure.
The first being that when you're counseling your young patients with, say, ET or PV, there is a mutation. Now, when you talk to them, do you tell them that it's malignant? How do you explain to them? The word cancer in our country carries a huge baggage, and they get very anxious about it. So my first question is, how do you counsel them? Do you use the word malignancy or cancer?
Well, it's very nice to see you again. Thank you so much for your kindness. Well, this is really difficult. I think perhaps it's important to think about how you describe these entities. Definitely, it's important, not perhaps. I do try to use the word cancer for my patients because in the UK, there is this terrible thing called Dr. Google. So if you say you have got ET or PV or MPN, my patients or their parents will go on the internet and then they will find the word cancer. So I prefer to be the person who introduces that concept and puts it in the frame of the kind of data we've seen today. But I think this is really very difficult, and it's a difficult topic, and I try not to cover it at the beginning of the consult, for example, but I'm interested in what your thoughts are on that.
It's always hard for us to use the word cancer. So I think first we gauge who's sitting in front of us and see their ability to handle information. And maybe as time goes along, maybe we broach the issue and we talk to them that this is not normal. And this is not like a regular malignancy where we have to give chemotherapy. So we kind of mollycoddle them a little bit. But like you said, we also have patients coming to us with Google knowledge. And that's why they blurt out the question, is this cancer? And then it's hard what to say because, they've got a good longevity. And therefore, we spend a lot of time counseling them that this is not like your regular cancer.
Exactly. And this is why one of the reasons I prefer to introduce it ideally at the beginning. I say, if you go on the internet, you will see this, because I prefer them not to have that really bad experience of finding out bad things on the internet. And then maybe they don't trust you so much. And the trust is so important in the aspect of the relationship between the doctor and patient, but particularly, I think, for these younger people.
My second question is that if you have a ET who is on, or PV who's on hydroxyurea, which is very common in our country, like we very rightly said that I don't know how many times it's indicated in the analysis that you did, but we find that they are on some cytoreductive agent. If they are planning a pregnancy, how long before pregnancy should we be stopping hydroxyurea?
Well, no scientific data for that. And this is, of course, relevant for male patients as well as female patients.
Yes, both.
First to say, there have been reports of pregnancies, and of course also in sickle cell patients and other indications for hydroxycarbamide for men who have fathered children on that drug and women who have got pregnant on that drug. But it's probably not something we would ideally want our patients to be on, although sometimes there is no alternative. Anagrelide could be safe for a man, probably not safe for a woman, but they could probably take that drug up to the time of conception and then make a change. As a broad brushstroke, the short answer to your question is 3 months, in my opinion.
Right. My third question is that you did allude to the fact that for some reason, JAK2 mutation positivity is associated with splanchnic thrombosis. And sometimes I've got patients with splanchnic vein thrombosis whose CBC is normal, but they are JAK2 positive. So why is there a predilection of JAK2 for the splanchnic system? Is there some reason for it? Is this biology? Is it different behavior of endothelium? Because the incidence is like 40 or 50% of patients with splanchnic thrombosis can be JAK2, which is little unusual. We don't see that in the limb thrombosis. So what's it that JAK2 takes a predilection to splanchnic thrombosis?
Another very pertinent question, and if I had been able to show that slide with the 2 humans and the circulations, oh well, we all missed it. It moved backwards and forwards so many times. We do also very much see that in these young people, and that it's so interesting. And we don't see it so much for CALR mutant, although it does happen. I think there are some descriptions of the JAK2 mutation being present in the vascular endothelium. Some people don't believe that data. I think it's possible. I think there's possibly also something about the mechanism of thrombosis in that circulation. Maybe it's more prone to the kind of blood stickiness that occurs in MPN patients, especially in the JAK2 patients. So we see leukocyte activation. Maybe it's also more sensitive to the raise in hematocrit, which we also see in those patients. I suspect it's multiple subtle issues, but it is another tricky area in this disease, and quite often these patients may well have had a silent splanchnic event, so it's worth looking on a scan.
My last question would be that, we've got patients with, say, PV, and we've got a hemoglobin which is not bad. I mean, it's about 15, 16. We do phlebotomy. But if they are associated with a higher white cell and higher platelet count, then does that hematocrit matter, or should we put them on some form of cytoreduction to reduce the risk of thrombosis?
Yes. Well, the basic principle of PV management, as you well know better than me, is aspirin and venesection. So maintaining the hematocrit below 0.45 and lower still in pregnancy, and possibly some people would take it lower still in a splanchnic vein thrombosis patient, maybe down to 40, is a basic principle. I think you're really asking me, when would I be worried about the white cell count and when would I be worried about the platelet count? And it depends a bit on the patient in front of me, but in a young, fit patient, for me, a white cell count which is over 15 merits watching. If it's 15 and stable in an otherwise well patient, maybe not so worried. But if it's 15 and rising up through 20 and persistently going up, I might want to think about a treatment. But it would depend also what treatment was available to me and what the risk of that was for that patient. For the platelet count, there's less evidence for the benefit of controlling the platelet count in PV. But for me, I would be worried about a platelet count in an otherwise asymptomatic patient of 1,000 or above. And I would definitely want to think about treatment, of course, if it reached 1,500. However, that doesn't mean that in a high-risk patient that it isn't important to control those factors. So if the patient has got high-risk features, has already had a thrombosis, then I think it is mandated to use something to control the white cell count and ideally the platelet count. And we recently demonstrated that the benefit of controlling the blood count comprehensively in PV in a second-line setting resulted in better event-free survival for patients. So it is important to look at these factors in a high-risk patient. Apologies for the long answer.
Thank you very much. It's always a pleasure to listen to you, and thank you for contributing to our knowledge. And on our part, we pass it on to our patients and make them more aware. Thank you so much.
Thank you so much.
Thank you, Dr. Abhibhave, sir. Dr. Sachin Jadhav, you have a question?
Yes, hi. Sorry, I'm unable to switch on my webcam. The question essentially is, in patients who otherwise look like PV, the serum erythropoietin is subnormal or within normal range, but are triple negative. To what extent do you investigate them for secondary causes of, polycythemia?
Oh, that's an excellent question. And so let's return to the erythropoietin level. So for me, a low EPO level is suggestive of a pathology, but how low it is really correlates with the likelihood of pathology. So an EPO level that is less than 2.5, which is is half of the lower limit of normal, which is 5 in our institution, is really indicative of an issue. But an EPO level, that's somewhere around 3 or 5, for me probably is a bit less interesting. If I've done a JAK2 V617F and an EPO level and a carboxyhemoglobin and taken a history from the patient, and the only thing that's abnormal is that the hematocrit is, let's say, 0.49 in a woman, and the EPO level is normal or up, then I think this is unlikely to be a polycythemia vera, and I would veer away from further investigation for that. But I would want to think about factors such as sleep apnea And if the EPO level is elevated, I would probably want to do some imaging. In a woman, I'd be thinking about fibroids, but I would definitely want to image the CNS. If the EPO level is borderline, I think it's sometimes worth repeating it. There have been historically quite a lot of issues with erythropoietin levels and their accuracy. And lastly, if the EPO level is in that very low range, I would want to know a few things. One, is there a family history? And if there is a family history, then we have to start thinking about things like link mutations, so SH2B3, or the rare patients with erythropoietin receptor truncations. And if you don't have the ability, and as well, of course, the exon 12 JAK2 mutations, which are more likely. If you don't have the ability to go beyond mutational testing in JAK2, exon 14 or 12, I think a bone marrow biopsy could be useful here.
All right. Thank you.
Thank you, Dr. Sachin. Dr. Aditya, your question, please.
Thank you, Dr. Harrison, for the fantastic talk. So I have two questions for you. So first of all, you had some patients in their first decade of life having been diagnosed with MPN in your cohort of around 450 young patients. So do you look for germline, JAK2 or other mutations in such patients? And what implication does it have on the longevity of such patients? My second question is regarding the management of polycythemia vera in pregnancy. So as we all know that we are the conventional teaching is to keep these patients iron deficient by regular phlebotomy so that we can have the hematocrit under check. But since pregnancy mandates, the iron supplementation for the growth of fetus. So what is the paradigm that you follow? Thank you.
Wow, thank you so much. Let's deal with that question first. So this is a point that I educate midwives on. Please don't forget iron deficiency. Please look for it. Please treat it. But for PV patients, I tell my patient, please don't let the midwife give you iron. If the midwife's trying to give you iron, please don't take it and please contact us. Because the fetus is very good at extracting iron from the mother, actually. And so I would, as a point of principle, almost never supplement a pregnant woman with PV with iron. If I do, I would give them maybe 1 pill a week and keep a really close eye on their hematocrit. And if I have one of my patients who's pregnant, I also write in her obstetric notes, please do not give this patient iron. So the other question you asked me was about the very young patients. And forgive me, could you repeat the question?
So my question was regarding the germline mutations. Yeah.
Yeah, sorry. It's still a little bit early in the morning here. So germline mutations, if you have the ability to test for them in a young patient, you could consider that. But you really need to have somebody who knows how to interpret what they are finding. And I think you would want to look there when you've got a family history. That brings me on to another point. So if I see a young child and I'm really suspicious that they have an MPN, I would almost always take blood from the parents and look at their blood count as well. But a hereditary thrombocytosis is a really, really rare event. We do have the ability in the National Genomics Testing Network in the UK to run a congenital thrombocytosis and a congenital erythrocytosis panel, but they are positive in less than 10% of cases. So I think it's not always helpful.
If I have the permission, can I ask one more question?
Please go ahead.
Yeah, Dr. Harrison, it's a bit naive question, but with the available the testing facilities, can we know the timing of event in JAK2 positive MPNs with the available testing facilities? And does it have any implication?
Wow, that is an amazing question. It's not a naive question at all. So you need to invite Jyoti Nangalia. I'm actually in Cambridge today, visiting my son at university. But Dr. Jyoti Nangalia has presented some beautiful data calculating phylogenetic trees using artificial intelligence and mathematical modeling. So we're circling back to the beginning of the webinar and the wonderful introduction and looking at the mutation rate. And it is possible to predict when the mutation occurred. And for some patients presenting in their 30s or 40s, the mutation was predicted to have occurred in utero or in the first few weeks of life. Some patients have a more rapidly aggressive disease that presents more quickly. And if you put side by side the phylogenetic trees for CML, BCR-ABL, and JAK2, they're completely different. This BCR-ABL clone is much more dominant and much more aggressively growing. And the same is also true of CALR. It's very uncommon to find CALR as a CHIP mutation, but it's very common to find JAK2 as a CHIP mutation. So, and actually returning to the previous question that came about how do I tell a patient about cancer? This is a fact that I tell them to try to reassure them. Actually, the data shows that you probably have had this mutation and you may well have had this condition for 10 or 15 or 20 years already.
Thank you.
Thank you.
Thank you, Dr. Aditya. Dr. Raj, your question, please.
Dr. Harrison, two very basic questions. The first one is, do you do a bone marrow examination for all your MPN patients, or do you have any exceptions? That's my first question. Second, among the ET patients, between the three mutations, is there any difference in cytoreductive therapy or the response to cytoreductive therapy among the three mutations?
For the most part, I would do a bone marrow biopsy in my MPN patients, but there are some exceptions. In the cohort of patients that we focused on today, young patients and pregnancy, if I think the patient's got an MPN, I will 99 times out of 100, I would do a bone marrow for those patients. For a very young child, you know, the kind of biopsy that we need, a trophine biopsy, can be difficult. So I would sometimes wait, but it's very useful in diagnostics. In an older patient where the diagnosis is clear cut and where any findings in the biopsy would not alter my management, then I might not do it. And if I'm in the situation where the biopsy would be technically difficult, for example, a very large patient, we recently had a patient who was 130 kilograms who presented at St. Thomas's with an intraventricular thrombus and was JAK2 positive. So she's fully anticoagulated and a very large patient, has all the blood count features of a JAK2 positive MPN. We didn't do a biopsy on her. I think that's helpful. And then you asked about, would I use, or was there any evidence for difference in efficacy of cytoreductive drugs across the mutational types? And do you remind me of some data from the PT1 study, which was a study we started to do in 1997. And in this study, we noticed that in high-risk patients, and hydroxycarbamide was more effective than anagrelide at controlling the risks of thrombosis and hemorrhage and transformation. But interestingly, that difference was, when you look at patients according to their mutational type, was only apparent for JAK2 positive patients. So anagrelide worked just as well as hydroxyurea for CALR patients or JAK2 negative patients. When we did that analysis, we only knew about the JAK2 patients, but we've subsequently done an analysis across the other genotypes. So, and that's probably because there's a leukocytosis and a slight erythrocytosis perhaps in the ET patients, and that the hydroxycarbamide is controlling that. Interestingly, if you look at molecular responses, it's more frequent to see a molecular response in a JAK2 positive disease than it is in a CALR positive disease with interferon as well. Great question.
Thank you, Dr. Raj, for that question. We have a question from the chat box, ma'am. Dr. Hita wants to know that do we need to anticoagulate patients with chronic splenic vein thrombosis and is JAK2 positive?
Short answer, yes. But there are sometimes some jeopardy in formal anticoagulation. So for some patients, you will have to liaise with the gastroenterologist. Patients who've had active variceal bleeding need better control of their varices, for example. Another additional supplemental answer to that is, should I add aspirin to formal anticoagulation? And my answer to that would be no, but it can be helpful sometimes if the patient has, for example, a tip shunt which is blocking or ongoing symptoms.
Thank you, ma'am. Would you prefer DOACs or VKA?
Yes, well, in general, we would usually start with a VKA, but there is more experience now with DOACs in this setting, especially in the non-Budd-Chiari patient cohort. So oftentimes these patients are ending up on a DOAC. Of course, we have to remember that a few things. One, ease of reversibility for vitamin K is there. It's not there for a DOAC. So if you've got a patient who's a bit more brittle or who might need procedures unexpectedly, although I think DOACs are much more simple to manage in the context of procedures. And then the other thing is, if you have a patient with recurrent events, you really need to use vitamin K antagonist because you need to push the INR higher, as you know.
Thank you so much, ma'am. Dr. Hita also has another question, that is there any thrombotic risk in post-plectomy thrombocytosis?
That is not linked to an MPN.
Yeah, it's different.
Yes. Well, I think the thrombocytosis probably doesn't add too much to the post-operative risk of thrombosis here. And so it would be rare for us to manage adjust a thrombocytosis in a patient without an underlying hematological condition there.
Thank you so much, ma'am.
Thank you.
Any other question for ma'am? Dr. Harrison? Well, there are no other questions, and I finished all the questions from the chat box. What a wonderful lecture, ma'am. Superb. Thank you. You were fabulous, and a great learning from you.
Thank you for the opportunity to speak in front of your fabulous colleagues.
Thank you so much, ma'am, for joining us.
Thank you for the opportunity.
Thank you, ma'am. I now request the Intas Pharmaceuticals to please go for final vote of thanks.
Thank you, everyone, all the eminent faculties, and especially Dr. Harrison, to enlighten the Indian faculties over here, and also all the students who have joined from across the country. Thank you so much, ma'am, and everyone for giving their valuable time and the excellent discussion which happened, which led to sharing of knowledge across boundaries. Thank you so much, Dr. Khurana, for leading the program, and MBA Agarwal sir for all the insights and keeping this show going on every Saturday and Sunday. Thank you so much, sir.
Thank you so much. Thank you, Dr. Harrison. Thank you, Dr. Rajan Kapoor, for being the chief guest for the day. And thank you, all of you, for present over here on this beautiful Sunday morning.
Thank you. Thank you. Thanks a lot.
Thanks a lot.